Hi, this is Brian Wilmers recording a lecture regarding the care of patients with renal urinary problems, specifically on chronic kidney disease for medical surgical nursing at the University of Sioux Falls. So some of the learning objectives we'll be talking about assessing patients who have chronic kidney disease, looking at the difference between acute kidney injury and chronic kidney disease, both for risk factors and some of the differences between the two. We're going to talk about identifying priority nursing diagnosis with those with chronic kidney disease and kidney transplants. We'll talk about chronic kidney disease and kidney transplants related to elimination, fluid and electrolyte balance, and acid-base balance. We'll talk about hemodialysis and peritoneal dialysis, and then we'll do some talk about education. So the first part here is both processes can lead into end-stage kidney disease. So acute kidney injury and chronic kidney disease can both cause kidney failure, and that can require dialysis or transplantation. Chronic kidney disease usually happens over a longer period of time and has gradual decompensation as it goes. Acute kidney injury is usually more acute in nature and happens more suddenly. In this lecture, we're going to be talking more about chronic kidney disease, and acute kidney injury will be more of a high acuity type of situation. So with chronic kidney disease, we're going to say that there's some damage to the kidney and it doesn't recover. Lots of causes for this, including hypertension, diabetes mellitus, and hyperlipidemia. This results in a building up of waste products. And so azotemia, uremia, uremic syndrome, all those things count for this. There are different stages for this, and different groups will arrange this differently, but you can kind of see how it's based on glomerular flow rate and what kind of volume that you're putting out. Can lead in cardiac changes. Part of it's because of previous history of, or potential previous history of hypertension. Otherwise, if they get fluid overload, that can throw them into hypertension and heart failure. Hyperlipidemia causes complications as well. Heart failure related to workload, anemia, hypertension, fluid overload, like we talked about, could cause pericarditis related to the toxins and infection that the patient might have. And of course, electrolyte imbalances related to increased potassium, increased sodium, and fluid retentions. There's also hematological changes. So where is erythropoietin made? On your kidneys. So if your kidneys are damaged, you might have anemia related to that. So GI changes, the stress might turn into peptic ulcer disease. They might get anorexia, not hungry, nausea, and vomiting. Fluid and electrolytes, as I said before, fluid retention, sodium retention, potassium retention, altered calcium, phosphorus, and metabolic acidosis ultimately. So I thought this was kind of a nice little demonstration, a nice little slide, but you can see how all these things cause hypertension, hyperkalemia, uremia, anemia, skeletal buffering, acidosis, hypokalemia. So all these things are going into this patient, and it makes them kind of complex sometimes to treat. Subjectively, based on their age, the older somebody is, the more likely they are to have complications to this. Male gender is more prevalent than female, but both can be impacted with this. Medical history, like we said before, hypertension, diabetes mellitus, lupus, arthritis, cancer, TB, all these are risk factors for chronic kidney disease. Any medications that can be nephrotoxic or contrast exposures can do this as well. And so with the history of previous illnesses, so nausea, vomiting, anorexia, diarrhea, constipation, decreased energy, shortness of breath, or bleeding can all be signs pointing to chronic kidney disease. So objectively, chronic kidney diseases will affect all body systems. It could cause lethargy, seizures, comas, hypertension, fluid overload, heart failure, pericarditis, dysrhythmias, S3 heart tones, jugular venous distension, peripheral edema, all those from being fluid overloaded. Crackles in the lungs from fluid, shortness of breath, tachypnea, uremic fetor, which is just bad breath, anemia, bleeding, bruising, petechiae, purpura. I think you know most of those terms. bleeding in stools, thin fragile bones, urine manifestations, jaundice, and a uremic frost. So this is uremic crystals that are sweat out of the body, and then when the sweat evaporates, it just leaves the crystals behind as a white kind of a frost, so to speak. Psychosocial, there's a lot of stressors involved with this about quality of life and next steps and what am I going to do. So the stressors in coping with this can be very significant. Diagnostics, UAs, can track the disease progression, especially when we're talking about glomerular flow rate. We can look at serum creatinine, BUN, trying to look at what the output is and how the filtering is going. And then, of course, imaging with ultrasound, CT, MRI, etc. So planning and implementation, hinted at this, or actually flat out said it a couple of different times, but fluid volume overloaded can lead into a whole host of problems from this. And so things that we'll do for interventions would be drug therapy, diuretics, is probably one of the more common ones with chronic kidney disease. And then assess that fluid status, I's and O's, weights, etc. And then probably putting them on fluid and sodium restrictions. They can get edema of their lungs, and of course that's a complicating factor too. And so things that we'll do for that is monitor them for signs and symptoms. We'll put them in a high Fowler's position. We're going to do supplemental oxygen as needed. Diuretic therapy, try and pull off that extra fluid. We can use some morphine for the vasodilatation process and try and open up that blood and that pathway. And then, of course, using pulse oximetry to manage the supplemental oxygen and track it. Cardiac output, so we talked about fluid overload causing heart failure, etc., etc. So we want to make sure that they've got stable blood pressure, stable ejection fraction, and that they're tolerating this well. And so we can give blood pressure medications as tolerated to get the outcomes that we want. Impaired nutrition, so oftentimes they have impaired nutrition. We talked about all the fluid and electrolyte shifts that they can have within their body, so we've got to be careful with that one. Really want to limit the amount of potassium and sodium that they get within their body. We want to maximize the calories and protein that they have, and vitamins, trying to maximize the good food and support that they need without the other stuff that might accumulate within their body, so fluid, potassium, and sodium. So we talked about all these kind of things. Risk for injury, so bleeding would be a factor with this one. Fall risk for a factor. Altered mentation can cause nasty side effects. Drugs can cause side effects, and so all those things can be a risk for injury with this one. So we do have to be careful with lifting and transferring them, as well as some of the medications that they're on. Risk for fatigue, so they might be tired, and so we've got to balance sleep and rest and group those cares appropriately. Support them with good nutrition, give them medications that can support that RBC production, usually erythropoietin, and then make sure you're doing an explanation of all these interventions well to decrease any anxiety that they might have. Some treatment modalities would be renal replacement therapy or hemodialysis, specifically on this one, in which the blood is coming out, going through a machine, getting kind of rinsed off, and then put back into the body. So, requires a dialyzer, anticoagulation, vascular access, usually like an AV fistula, or it could be different indwelling ports and caths. Post-dialysis, so we're going to watch them for equilibrium syndrome, and that means that the fluid and electrolytes are shifting within their bodies and they're not used to it. So nausea, vomiting, hypotension are real complications of this. So watch them on the vital signs, look at the weight to see how much we pulled off of them before and after they do the dialysis. Look for any bleeding afterwards, and then of course you might check a sugar if you feel like they're low. Now another type of dialysis would be peritoneal dialysis, in which you have an abdominal catheter in which you can infuse dialysate. So the clean dialysate goes in, it's a hypertonic solution. Since it is usually kind of a sugar mixture, it pulls in the waste products, and then you drain it out. When you drain it out, the waste products go with it. So, may require some heparin and potassium and antibiotics, but it's not nearly as common to have these type of situations as with your hemodialysis. So, side effects, they do get some electrolyte imbalances because of all the shifting electrolytes and waste products going into this dialysate. So watch this. When you infuse, think about it, you are infusing a couple of liters of fluid into that abdominal cavity, and that can cause some discomfort. And so we're going to continue to monitor. We want to make sure that when this comes out that it is translucent, we're not seeing any big particulate or signs of infection. And then we'll manage that time flow, depending on how the patient's tolerating this. If they have a lot of, as you're infusing all the stuff, it can cause constipation, and constipation inadvertently could cause pressure on this catheter and not drain it as well. And so those two can go hand in hand on this one, unfortunately. Kidney transplant would be another way to do this for end-stage renal failure. With this one, kidney transplants can be from donors, it can be from cadavers. They're starting to do all the stem cell transplants and scaffolding and stuff like that that's related to having the patient grow their own kidney, which I think is amazing. I'd love to see that happen. But they do have to match. And so the tissue match is an important concept of this, and you can't just put any organ in any person. You have to have a good tissue match. And so related donors often do really, really well with this, but if we could use stem cells and get like the same tissue, then that would be amazing as well. So post-operative care, so we got to make sure that we're giving the immunosuppressant drugs, make sure that they're within therapeutic levels and but not being toxic. Ongoing kidney assessment with this one, what's your output doing with this one? That's one of the main features of this, and we can look at BUN and creatinine. And then look for any signs and symptoms of rejection. We'll talk about that more on the next page. Or signs and symptoms of infection. So specifically hyperacute rejection, so this is minutes, hours after the graft. I knew a family that the dad gave it to the daughter, gave a kidney to the daughter, and she rejected the kidney while back in the operating room, and they had to remove the kidney. Since it did have, since it was reacted to, and there were antibodies on it, then it couldn't go back into the dad at that point in time, and so that was kind of a sad situation for them. Acute rejection within 3 months, so this is usually more of an infection, or you might see this as related to a clot. Chronic rejection, so loss of that graft. You're going to see this over time. Some transplant docs will say that your chronic rejection is happening from the day that you put the kidney in, and that it's slowly, your body's slowly rejecting. So realize that that can happen as well. We do have to worry about renal artery stenosis or vasoconstriction or vaso-occlusion with this, so clots are very real, and that can cause complications. Likewise, if the kidneys are not getting enough blood, you know the whole drill, that's going to cause more squeeze, cause hypertension. Increased hypertension is going to narrow these, and for the blood pressure aspect of it, but then you get poor perfusion, and so it's kind of a nasty cycle. Additionally, with all the meds that they're on, they are at increased risk for immunosuppression complications with infections or tumors. So there are some definite complications related to kidney transplantation. This finishes this PowerPoint presentation. If you have any questions, please let me know.